Okay, I think we'll get started here. So welcome everybody to our interactive webinar today, which is going to be focused on, can you just go back to that slide, please? Investigating the impact of Perinatal Psychiatry Access Programs on treatment participation. So this came out of the reason what spurred this webinar was that people had asked. We appreciate everyone who's filled out the survey that we put out, and people had talked about wanting a bit more in program evaluation, and people had also asked specifically, I got an email from a couple of people asking about how do you use claims data to evaluate access programs. So that's what we'll be focusing on today, because a lot of the people on network have been asking for that. And next slide, please. A couple of housekeeping things, and I'll introduce our speakers. So as always, please stay muted if there's background noise, but please, unmute when you want to participate. It's also often a sign for us that you want to say something when you unmute, so that's helpful. We will be recording the meeting, and as always, if there's Dee's email if you have any technical difficulties. Next slide, please. So just a couple of announcements before I introduce our speakers. So we're very excited. There's some really, despite that there's a lot of very challenging things happening in the world right now, there has been some good news on the maternal mental health front, that Congress had approved funding for maternal mental health in the most recent stimulus package. There's a couple of things that are really exciting for us on our network. One is that there was $3 million to create a new maternal mental health hotline, which I'm sure we'll be hearing more about. And I think our network can hopefully be a way to facilitate that. And the other thing that's very exciting is $5 million to continue the HRSA screening and treatment for maternal depression-related behavioral disorders program, of which many of you are awardees. So we're really excited about that. And we've had a lot of focus on sustainment and about advocacy. And I want to call out all the people here who were very, very involved in advocating that. I see Adrian Griffin on the here, and I don't know if Jamie's here, but many, many people here have been really involved in that. So deeply grateful for that. I'm sure we all are, because a lot of you are funded through that mechanism. Next slide, please. And just a couple of upcoming network activities to update you on. So as always, we have our monthly convenings. The next one will be on February 9th. We're going to focus on provider outreach and engagement. We've heard some feedback but this is an ongoing challenge. So we're focusing on February 9th. And on March 9th, our topic is to be decided. But those are the next dates. Next slide, please. So very pleased to introduce Ayse Akincigil, and who's at Rutgers, and Tom Mackie, also at Rutgers. So so I know Tom we became, we're co-PIs or dual PIs on a grant together, which you're going to hear a little bit about today. It's been a wonderful collaboration. We met a few years ago, and we've been doing this program evaluating the access program. So we're very pleased for Tom to come today. And then Ayse is a health economist, and her focus has been on reducing inequalities in healthcare quality through reforms in healthcare financing and delivery models. So when we heard that you guys a lot of people in our network wanted to hear about this, I reached out to Tom. He said, I got the perfect person, Ayse. So we will be hearing from them today. We're very pleased to have them here. And thank you both for being here. And I'll transition it over to you. And this will be interactive. So if you have questions in between, please enter it in the chat box, because we want to have this be interactive. So enter in the chat box, and I'll be moderating, and we can stop in between. So we definitely, please enter into the chat box or unmute if you have a question. We welcome an interactive discussion throughout this.
Can we have the next slide, please?
Josephine, do you have the slides up? Here they come.
Thank you, Josephine. Thank you so much. Thank you so much for that nice introduction, Nancy. And I joined the team through Tom because of the collaboration between Tom and Nancy, because I've been working with Tom for over 5 years now. And this is like the third grant we're working together with Tom. And I'm so looking forward to working on this one, because maternal depression, perinatal depression has been a big interest of mine, but lately I've been mostly focusing on elderly mental health issues. So having a chance to go back to this is very exciting for me. There is a poll I want to push, if possible. I'm curious about your experiences with using Medicaid claims and using measures derived from claims for quality assurance, for evaluation, for research. So what's your experience with claims-based evaluation measures? And please check all that apply.
Just going to keep it up for a couple more seconds. We have about a little over half of people have responded. Right, I'm going to close the poll now. Thank you, everyone. And I'm going to share the results.
This is very diverse. Well, thank you. Thank you. I will pace my talk accordingly. So hopefully everybody will have something, a few things new to find out, but a lot of things might be repetition for you. So next slide, please. So here's the motivation for our talk. The two questions that always keep our minds busy as clinicians, your minds busy as clinicians, me being an economist, not there yet. Consider healthcare services received by an individual. Does it meet the standards set forth by your organization? Or looking at it from a population perspective, what % of patients meet those standards set forth by your organization? Going more specifically to today's topic, applying this bigger question to the more narrower today's topic, does the Perinatal Psychiatry Access Program improve the treatment engagement of Medicaid insured women and other perinatal individuals? So these are the questions that keeps us busy most of the time. Next slide, please. And there are many ways to answer these questions, provide empirical evidence to answer these questions. And I've listed them here. This slide summarizes the pros and cons of every approach, but I'm going to talk about how administrative data has advantages and disadvantages compared to the other methods in the upcoming 15 minutes or so. Next slide, please. So these two questions that motivate this talk. I'm going to show that Medicaid claims can provide relevant evidence to answer these questions, but it's going to provide those evidence only under some specific circumstances. And the objective of today's talk is to facilitate a discussion of these circumstances with the within the context of prenatal care. Obviously, these can be applied to any topic within healthcare, but today I'm going to definitely limit it to perinatal care. Next slide, please. Going back to that first question, healthcare services received by an individual, does it meet the standards set forth by your organization? So in principle, all healthcare encounters can be tracked by bills, these bills that are submitted for reimbursement. These bills record every diagnosis, procedure, prescriptions filled, services dates for every inpatient, outpatient, and prescription services received. So it allows us to calculate if this patient's care meets the benchmarks that are set forth by whatever benchmarks we're talking about. That is also another discussion for a different day. But do we meet some benchmarks? And claims data will give you the date information to see certain benchmarks are met. And the most important principle of this approach is the participation, treatment participation and utilization data derived from these billing data, in principle, will be reliable and valid, because if the provider doesn't bill, revenues will be lost. If the provider bills more than what's provided, then it's fraud. So we have a lot of mechanisms in there that will make this data reliable and valid compared to other data collection sources like survey reports, interviews, etc. A lot of attachments that come with billing data compared to other data that makes it valid when it comes to utilization. Next slide, please. Indeed, as you're familiar, particularly with the HEDIS measures, claims data do generate many care quality indicators. This is a snapshot from Medicaid CHIP health quality measures. It's basically reporting state level data on appropriate timing. What percent of women who gave live birth has prenatal care in the appropriate timing? The operationalization is between 21 and 59 days, actually. So the claims data are used to generate this kind of data. And they're used to report on quality at the state level and other things, which I'm going to discuss later. Next slide, please. What is so amazing about working with claim data? You can just work for your organization. You can just focus on your organization, or you can go bigger, doing a lot of comparative effectiveness studies. Actually, studying Medicaid data will generate evaluations for very large population-based samples. Now, particularly in our case, Medicaid insured women and other perinatal individuals. Now, this is a snapshot of the first 12 states or so. I have the reference here from Kaiser Family Foundation. It has all 50 states, and there are a couple of states that don't have the data, so we don't have the United States data up here. But if you exclude those states, approximately 1 in every 2 births is financed by Medicaid. So this gives a huge access to conduct many studies, many quality, many things that can drive policy. Next slide, please. So remember, there were claims and there were other methods. Strengths of claims-based approaches for program evaluation is the number of women covered. You can study everybody who's paid by, in case of Medicaid, if you're interested in Medicaid populations. It's capturing data without any primary data collection for such large numbers. These data are generated to pay, to get reimbursed. So data are out there readily available. And the other thing is there's no loss to follow up with this data. You know how horrible loss to follow up can be if you're doing survey research, particularly with Medicaid insured populations. And the validity of the utilization data, like I just discussed, underreporting results in loss in profits or loss in reimbursement, and overreporting results in fraud. But obviously everything comes with caveats. So let's talk about that later. Next slide, please. So the first principle, these data, utilization data, are valid because of those incentives we discussed. But the second principle is, and this is any topic you study with claims data, you should keep this in mind. Elements of claims data are reliable only when those elements are required for reimbursement. What do I mean with that? For example, this screenshot is a part of a pharmacist screen when the pharmacist is billing for dispense. Everything that's required for the pharmacist to get reimbursed is denoted by a star. Look at the diagnosis here. There's no star. So the pharmacist is not required to put in the diagnosis that came with this prescription. So when someone comes to me and says, I'm going to study pharmacy records and I'm going to study off-label use of, let's say, some psychopharmacological drug, off-label use of benzos, something, I'm like, hold on a second. You cannot trust on that data. If you're going to do it with claims, that's not going to work. That has a fatal flaw. Diagnosis is not a required element for payment. You can't trust on that data. Next slide, please. Now, I have another case study where it's more applicable to our group. Let's say, so preterm birth, as you know, is associated with increased risk of postpartum depression. So targeted interventions for the women that experience preterm birth or low birth weight may be beneficial. So let's say I'm interested in identifying this population and developing some interventions. Can I identify the target population with claims? Indeed, I can, because there are codes, as you probably all know, much better than me, to indicate preterm or low birth weight. But when we step back and think a little more, we realize that these claims will not capture all the infants born preterm or with low birth weight. They will capture the subset of infants who require medical care due to complications of prematurity or intrauterine growth retardation, because they need care. But then if the infant doesn't need care, no one is providing care, no one is billing for it, so this method is not going to capture them. In other words, you will miss the mothers dealing with difficult infant temperaments, the situation which is associated with higher likelihood of postpartum depression. Next slide, please. When I talked to Nancy about this, obviously we talked a lot about postpartum and prepartum depression. So one thing of interest to this group, she said, would be the depression screening. So I was wondering if I can identify correct prevalence, correct provision of depression screening for certain populations here. I did some search on the internet. I went to the American College of Obstetricians and Gynecologists website. They have practice management guidelines. They have coding and coding libraries, guidelines for that. And they have a lot of provisions about what can be billed, what can't be billed. So if the physician is providing the global obstetric service, then you can't bill for depression screening, even if you do every time your patient comes in. But then if the patient, even if you do that, and if the patient tests, if you diagnose depression, then you can report it separately, because your global service is for uncomplicated care. If you're doing individual, not global, but individual billing, you might need different codes for different methods of searching. If it's an automated electronical psychological test, you need a different code. But after every stipulation, it's a long list that Ayse gave, physicians should check with their specific payers. Every payer is different in what they accept, what they pay. With such variability and your chances of not getting paid, a lot of providers may choose not to deal with it. Next slide, please.
Ayse, there's a question in the chat box.
Yes.
So does Medicaid data allow for maternal offspring linkage? That's a great question.
Excellent, excellent question. No. Last time I checked, you need to work with birth records and do the linkage using the birth records.
Actually, I just found an article. There's some recent advancements on this, and so there's just an article that actually provides information about an approach that was found to be fairly reliable for women-infant linkages. The caveat that they provide in the article, which is consistent with my understanding, is that it requires the mother to be enrolled in the Medicaid on the child's date of birth, and then also accurate recording and consistent use of the case number within the family. So you may not have an exact, obviously if a mother is not enrolled in Medicaid, you're not going to create the linkage at the time, if they're not enrolled at the time of birth. If they become enrolled later, they become challenges with the identification. And there also need to be an alignment in the delivery date of record and the child's date of birth. And so there have been ways to facilitate that linkage when those pieces line up. What they found is fairly good reliability in some studies that have used this particular methodological approach to facilitate the linkage. And so I provide a link to an article here that just can provide you additional detail and information. It's a nice methodological article that specifically explores, specifically looks at the ability to facilitate the linkage. So it does appear that can be something done and be a reliable approach, but with caveats, as I mentioned.
I'm also curious if this is probably valid for CHIP when the mothers are enrolled because they're pregnant, but for the mothers that are enrolled for low income, before even getting pregnant, those would be hard to match to, I assume, this method. There might be some other approaches people might try, exactly like, data, you can match date of services and providers, maybe. Again, none of it will create an exact match, but there are some ways to get around it. The ideal way of doing it is to merge birth records with Medicaid data. But the problem with that is usually, at least in New Jersey, I don't know about other states, but in New Jersey, Department of Health has the birth records, Department of Human Services has the Medicaid data. And, it's the mayor that connects them.
Yeah.
Commissioners. So you can imagine how hard that could be, even for Department of Health people.
Right. A number of states do have databases that are linked, and or there are existing ones that for commercial insurers that are national databases that provide that linkage too.
God bless them.
Can I say something?
Yes.
So this is Carolina. I used to work with Medicaid and with children that are in waiver programs, and if any of the children in the home have mental health issues, or any of the adults in the home have mental health issues, the Medicaid benefits will cover everybody in the home with it. So these expenses could go that way. And this is specifically for the case of the innovations waiver that we are familiar with here in North Carolina.
So what state is this?
North Carolina.
That actually, I think this is a good time to mention this. Just because you know how to do research in one state with Medicaid data doesn't mean you know any other 49 states. That means you just know one state. I mean, I'm giving you the general principles, but there are so many state-specific things, just like the one that was discussed for North Carolina, that local knowledge is so critical with this kind of research. So again, looking back at the big picture without state knowledge, 2 principles. These data are really good because they're tied to payment. But then they're only good if they're actually tied to payment. I mean, if you use parts of the data that are not tied to the payment, if you need to make inference, indicators that may not exactly strongly tied to the payment, there will be issues like underreporting of mothers dealing with babies with preterm birth or low birth weight, just like the example I gave. The third principle is you need the mothers fully enrolled during the period you're studying. So for example, in the world of claims, this is the birth date, your programmer will come and call this index date, probably. That's the language of the claims programmers. This would be our index date, the date of birth. To be able to clearly say what happened during the pregnancy, the mother has to be enrolled in Medicaid for all the 40 weeks. Next slide, please. So if the Medicaid enrollment, let's say, happened 120 days before the birth, which is the index date, there is no reliable way of identifying the first prenatal visit data, the first prenatal visit date. Next slide, please. So actually, when you look at these claims-based quality measures, they find ways to get around it. This is a claims-based quality measure that are for timely prenatal care. So what they're measuring is trends in percentage of pregnant women with a prenatal care visit in the first trimester or within 42 days of enrollment. So they can't just report women with first trimester, because a lot of women are enrolled during pregnancy, not before pregnancy. So as a quality measure, they don't even report. I'm sure there are ways to report it, but these are the numbers that they're reporting to show what states are ahead, what states are behind when it comes to timely first prenatal care. Next slide, please. And I might ask you, how many women lose benefits after 60 days after birth? I'm sure the answers are state specific, and I have great hopes about with the new administration for the 60 days to go up. But next slide, please. The current situation is the blue bars are coverage levels for pregnant women, income coverage levels for pregnant women, and the orange bars are the coverage thresholds for the parents. So if you're studying postpartum care after 60 days, you're just limited to these people based on which stage you are in. Next slide, please. So those are the three principles. They're good as long as data are used for payment, data are required for payment, and the people that you're studying in the period you're interested in is enrolled in the program. Those are the three principles that I always think about when I'm approaching any issue with claims-based approaches. But even with these limitations, it's a powerful approach to calculate treatment participation, you know. And you're familiar with HEDIS, most of you, and you know behavioral health HEDIS measures that rely on claims. Because all of these limitations and strengths are known, HEDIS generated all these measures, and they're so strong that they're using these measures to accredit plans, to compare plans, compare and contrast plans, and publish that data. The two HEDIS measures that are particularly relevant for our study with Tom and Nancy is probably antidepressant medication management measures. There are two of them. One is like the 8 weeks post new depression diagnosis, and another one is the longer term, like the 8 months. Follow-up visits after hospitalization for emergency room department visits for mental health or alcohol or other drug abuse. There's hospitalization. Has there been outpatient follow-up care? These are very easily calculated with these claims. And there are other measures that, for example, people with severe mental illness, schizophrenia or bipolar disorder, are they being screened for diabetes and cardiovascular disease? How about people living with schizophrenia? Are they adherent to their antipsychotic medications? So there are a lot of measures that are already out there and very strong, and strong enough to be used as a benchmark for accreditation and for comparison. Next slide, please. So you know how programmers say, let's get our hands into the data? This is how it looks. This is your typical CMS 1500. I mean, these days, everything is done electronically, but this is what a claim looks like. When you provided your services, data went into the billing department. This is basically what billing department produces to get reimbursed. Everything is alphanumerical. By the way, sometimes an encounter generates even more than one claim. And look how complicated this single claim is. So we're talking a lot of, not just a lot of women, a lot of data for each woman. So we're talking about a system where if you want to work with this data, you will need a good programmer, data analyst, and data cleaner, data analyst, and you will need some computing infrastructure to work with that. So I just want to make sure that that is also in the picture. You should see they're good, but this is another caveat. It's not an easy thing to work with. It doesn't come in like your survey data. Next slide, please. So let's say you decided to develop a project that uses claims data. You have the programmer, you have the infrastructure. Now, how can you access this data? Because Medicaid is both federally funded and state funded, both groups have the data. Data sits at CMS with the feds, and data sits in the states. If you choose to obtain the data from CMS, these data would be standardized, they're cleaner, they're well documented, and every data comes with data quality issues. When you get the data from CMS, data quality issues are analyzed, reported, Plus, there are established procedures for data access. They're established, they're documented. You can find everything on the internet, step by step, how to access this data, how to pay for it, etc. But these data come in a lag. More importantly, state-specific fields are lost. For example, that waiver program we just discussed in North Carolina, how much of it will be reflected here in a CMS data is a question mark. It may or it may not be, okay? Another advantage of working with the CMS data is there's an organization whose mission is to help you find, request, and use the data. It's called ResDAC. It provides consultations, workshops, online webinars, videos, knowledge-based articles, and national conferences, and their services are free, but the CMS data aren't free. So it's kind of worked into that. Or you can work with states, obtain data from the states. If you obtain data from the states, data are current. Data include all the details, the programs that may not make it all the way to the federal databases. Documentation could be hard to locate though, because at least the data from CMS comes from a lot of filters and get ready for researchers. This is just operation data. And finally, states may not prioritize these partnerships. I mean, they can barely, there's so many responsibilities that they're getting to, and it's a hard thing to crack. Even if they want to work with you, they may not have the resources to de-identify these claims and share it with outside organizations. So next slide, please. A potential access point for state data is there are some existing partnerships, centers and universities that work with the states. These existing partnerships between Medicaid policymakers and their resident state or state-related university research claims. We have one in, for example, at Rutgers at New Jersey, Center for State Health Policy. Indeed, all of these yellow states have, the Medicaid policymakers have partners in the universities that have this partnership where basically there's a highway from the state to this academic organization where the data flows. There are established relationships, there are established data use agreements, etc., etc. You know, for example, at this stage, if I want to do a study where I need to merge birth data with the claims data, the people at Rutgers that are in the center have been working on it for 15 years, and now it's possible. I won't have the luxury to work 15 years on that to get to that research, but I can partner with them because they've already done the work. So that's another potential access point for state data. Next slide, please. Oh my God, it's already 34. So I want to give you the option to talk. These are some potential behavioral health HEDIS measures that are already been measured and reported. What would you be interested in knowing using claims data? And we can discuss those. How you apply those 3 principles. Think thoroughly about it. Think about your state conditions. What would you want to know using this kind of data?
Ayse, I'm curious to hear, because I know some of the access programs, this questions come up a lot, is around, okay, so like for a lot of the HRSA funded programs, they're, you know, in the NOFO, the Notice of Funding Opportunity, it says, you know, that they need to screen, I think it's 100% of the time to screen, you know, for mental health and substance use disorders. And there's specific things around that. And there's some other measures as well. So I'm curious for any of I know there's pretty specific measures, and I know that people have often asked, well, how do we get at that screening data? That's one question. And please, those are funded by HRSA or other states, other questions people have, but that's certainly one thing that I've been asked a lot. And how do you get at whether providers are screening?
That is an excellent question. Actually, after talking to you, Nancy, I went in and checked what does HEDIS have for prenatal depression screening. And they have a proposed measure for prenatal depression screening. And that proposed measure is based on a pool of data that comes from electronic health records, registries, chronic care condition management databases. Like, there are a lot of other data that surrounds the individual patient other than the claims. And they are proposing to use those to measure screening. And the proposals are in there. The two populations that HEDIS is focusing on is one, the perinatal depression screening, and the other one is adolescents, actually.
Mm-hmm.
But claims is not a part of it. Claims is a part of it only if there are some electronic health records where data from claims come in, some data from claims come in. Sometimes you get flags showing that the person didn't fill their medications that they're supposed to fill, and this and that. If that data comes into this care environment, then it could be a part of it. Otherwise, this other box of data where they will use, for example, for depression screening, is independent from the payment data. But the thing is, that data isn't as reliable as payment data. So these measures will be reported, but they're not going to be used for accreditation, and they're not going to be used for comparisons of organizations or states, because that all depends on the data infrastructure. I mean, to get to that level, we need full interoperability and full data reporting to get that data to the point where it can be used for accreditation and payments,
Mm-hmm.
quality-based payment, etc.
Mm-hmm. That's helpful. Thank you.
You're welcome. Well, so that's how I came into working with Tom on this project. I had the general knowledge of working with claims for almost 20 years now. I've been working with claims. I had applied them to very different topics, including mental health, but I've never worked with perinatal care. But that's what I was able to bring into the project that Tom and Nancy are leading. So I want to let Tom to continue talking, but there's a question. Let me answer that, Tom, before I leave the mic to you, okay? Does anyone have a link to the document that shows how much Medicaid will reimburse for screening? I think it depends from state to state. There's an S code. I looked at the state, Massachusetts, for example. I don't think Massachusetts is paying for it. I think Massachusetts wants the providers to report for it so that they can measure who is getting screened for. I don't think they're paying extra for screening, although they want it to be reported. I might be wrong. Again, 50 states, 50 state means 50 different rates, 50 different documentation, 50 different codes, maybe. That's a very state-specific question.
Yeah, and to answer a question about Massachusetts, or Tiffany, were you gonna, I think I maybe saw, do you want to answer that, Tiffany? I think I saw your mute come off.
Yeah, I was gonna say, there is, depending on the insurer, there is some reimbursement, but it is really very, very modest, and such that it hasn't really been incentivizing people clicking the extra button for it.
Mm-hmm. Yep. Yeah, and they screen, for mass health, it's once in pregnancy, once postpartum, but there's been, we'll save the details, but there's been a lot of problems with implementing it. And DPH here has a regulation to screen, but it's completely underreported because it's not really incentivized. And in fact, people are getting billed, like people with private insurance end up getting billed and getting foot with $100 bill for getting screened. And so it's caused major problems. So some practices just don't screen. So it's really problematic. And based on my experience, and I think Tiffany's as well, it's very, very unreliable. And looking at claims data in Massachusetts would not be a reliable way to get at screening data. And I anticipate it may be similar for other states as well. But I can only speak to Massachusetts experience. people may have things to add from other states.
So, for example, with Medicare, things are a little more regular. At least Medicare is just being Medicare being just federal for elderly. They get paid once, so usually it's a little bit more reliable. But like you said, 50 states, 50 different rules, and you don't want to burden your patients so that you can click a box and get a few more dollars.
Exactly. I think, Jimmy, you're going to add something. I see Jim has his mute off.
Yeah, no, thank you so much for this great conversation. I work at the Rhode Island Department of Health. We also have our all-payer claims database. And what we've been looking at is we've worked directly with practices to get the screening data. We pay for that. But one area where we would love to sort of use either this Medicaid claims approach and also with our all-payer claims database is to look at treatment. So I didn't know if there's been any sort of protocols that Lifeline4Moms or yourself that have sort of defined behavioral health treatment for perinatal patients. Like, what are those codes? We at the Department of Health, obviously, is similar to most Department of Health, have very limited capacity to create a design approach. It usually takes about a year, I've heard, from soup to nuts to get something out of the claims database based on all the review processes that have to happen. So I was just curious to know if you guys were aware of a treatment for depression, anxiety, substance use, whether it be sort of medications or counseling codes or whatnot. If any states or this network has done that we could just replicate, so we could get the ball rolling post a COVID surge to sort of look at different points in times to see, given the launch of our teleconsultation line, pre-post, has there been a difference in utilization globally and also among our enrolled providers? But I was just curious to know if that exists, because just replicating something that's already been sort of done, and I heard it takes like a PhD level to know all the codes and the minutia of that. So just be curious to know if you're familiar with that.
I am to an extent familiar with that. Depends on, again, what you want to measure, but the codes are out there and I know how to get them to you, Jim. In the next slides, Tom is going to actually describe some of those measures that he's using, him and Nancy are using in our study, and I'll be the one ending up implementing them. So we can have an offline discussion with the actual codes, the CPTs, the ICD-10s, and etc. Definitely talk more about it. But Tom can give us a big picture of those measures. Okay, next.
No, thank you.
Were you going to add something? Oh no, Tiffany took her. Okay. Tiffany, you were going to add something?
Yeah, go ahead.
Okay.
Great. So I think that's a really nice segue, actually. So I may take advantage of that and just take us to the next set of the slides here. I do want to articulate that there's also, this is not part of our PCORI study, but there's also increasing use of claims-based data sets to cost what the benefit of particular approaches or innovations might be, and to do, cost effectiveness studies, et cetera. So just to say as well that, you can also do some really interesting work with claims-based data sets around costing the impact of different interventions or approaches that may be occurring in a system or across a state even. And there are resources available if folks are interested, particularly in looking at things like return on investment studies using claims-based data sets. It's just an area where I think there's a lot of movement happening currently, and certainly an area of interest to Medicaid stakeholders. So sometimes you can get more, frankly, a bit more buy-in from a Medicaid partner to do these analyses if you provide the costing estimates alongside the effectiveness work that you're doing. But I want to spend now just a quick moment to talk a little bit about our study, and I should say I appreciate Ayse kind of providing particular credit to Dr. Wyatt, to Nancy and myself with regard to this study, but it really has been a collaboration of a number of individuals, many of whom are on the call. So I just want to take a quick moment to kind of recognize Deb Cowley and Amrita Bhatt at UW, University of Washington, from Pal4Moms, who were partners in this study, as well as Wendy Davis at Postpartum Support International, who is a partner in this research, and of course Lifeline4Moms and both Nancy and Tiffany. So this work really would not have been possible without this really great dynamic collaborative team who've put in all the work to make this a reality. So I just want to start by kind of giving an acknowledgement to the team that was required, and of course Ayse and their other collaborators here at Rutgers working on this study too as investigators. And so just real quickly, I want to kind of introduce the study and then use it as a little bit of a case study about how we think we can use claims-based data sets to facilitate an evaluation, just as Jim was mentioning, of what might happen when you implement an access program. We're using it as well to look at the comparative effectiveness of access programs, as well as of access programs and a referral program in New Jersey. So not only to look at just the difference that may occur within your state, but also the comparative effectiveness of what might be happening in the approach that you take as opposed to another approach to provide support and address and build capacity for providers in perinatal, in this case, perinatal depression treatment and engagement. So our PCORI funded study is called Evaluating Lifeline4Moms. That we really wanted it to be larger in its implications than just the 3 states. And so we positioned it as such, right? Wanting to contribute to the work that you all are doing and our understanding of the comparative effectiveness of different program models on both perinatal treatment, engagement, and quality. And if we go to the next slide. Our goal here really is is in 3 aims. And so we recognize the very first thing that the study needed to do is to really characterize the program components, timelines, and the state policy context across the 3 states that are of interest to us. So if we're going to evaluate the comparative effectiveness of these programs, we have to really understand, what was the implementation timeline for the program? Did it incrementally roll out across the state, such that only a small catchment of the state initially received the intervention, and then it began to kind of expand to other areas of the state. But that level of detailed information would be critical to our evaluation effort. So our first aim really intends to kind of characterize the implementation effort as it occurred. And in particular, we're interested in both the Perinatal Psychiatry Access Programs implemented in both Washington State and Massachusetts. So PAL4Moms, the Partnership Access Line for Moms, as well as MCPAP4Moms in Massachusetts, which have slightly different ways within which they operate. And we have talked previously on these calls, if you've been a part of them, about these program components of training and toolkits, resources and referrals and consultations. But looking at the differences that exist between these 2 access programs and the model that they implement, and what might be the associated differences in treatment engagement associated with their different approaches. Then we also have the state of New Jersey, which has implemented quite a different approach. It's implemented a universal screening protocol for perinatal depression, and then has a regional consortia that facilitate referrals to appropriate resources where there may be concerns indicated in that initial screening. And then also provides a speak up when you're down, a hotline for particularly for serious conditions that may arise with regard to perinatal mental health conditions. And so when more elevated concerns arise, the availability of the hotline to provide. And those services are both patient and provider facing, with more of a focus on being patient facing than the access programs, which we would characterize as having a stronger provider facing, really to build provider capacity. So we're interested in the comparative effectiveness of both the different models of access programs, but also the differences between the access program and the referral program, and where we see differences in their respective effectiveness. If we go to the next slide. So to initially characterize those approaches, and then to look at how the programs within their respective jurisdictions facilitated reach, right? So looking at a process evaluation in the second aim, and evaluating the variation in the reach and the utilization of the access and referral programs by looking at the programmatic data. So this is looking at data about the number of trainings that were offered, the number of consultations, the types of practices and providers that received those consultations, and characterizing the distinctions across the respective programs. So if we just move to the next slide. And then in the third aim, and this is the one I'm going to focus on, but I wanted to give you the context of the first 2 aims so you could understand how you were then coming into this comparative effectiveness aim. So by then engaging both our understanding of the implementation process and the adoption of the access and referral program, and by understanding its reach, to the jurisdictions, to the specific catchments to which it was being particularly effective, then looking at what is the comparative effectiveness of these programs on treatment engagement or treatment participation, as Ayse had mentioned previously. and looking specifically at the impact of the program, the Perinatal Psychiatry Access Program and the referral programs, and their differential impact on outcomes. So to do that, we're using Medicaid claims-based data. And if we go to the next slide, you'll see here that there is, we're using both data that is available through ResDAC. The Medicaid analytic extract is the CMS data that Ayse had referred to previously. And so that's the centralized data that is available through an initiative at Minnesota, an organization called ResDAC. And so they provide training, they provide data quality repositories so we can assess the quality of these data. One of the things I should say that has happened is the data file structure changed in 2014 to 2017, depending upon the state. And it moved from what we call the Medicaid analytic extracts to the TMSIS file, or the Transformed Medical System Information Management. And so TMSIS is a system, and so that's a different file structure. And so one of the things we have to work with is facilitating and integrating those two different file structures in this study. But that being said, we have the data available from ResDAC from 2001 to 2018, and then we have data available through Mass Health directly from the state Medicaid agency in Massachusetts that we're going to be engaging from 2009 to 2018. And so you'll notice here the time lag point that Ayse had mentioned, in that we already have Mass Health data available to 2018 currently, but the time lag for the data available through ResDAC is considerable, between 3 to 4 years after the data it particularly reports on. And so we have a time lag and won't expect to receive the 2018 data. We actually think we may get it later this year rather than when we had initially anticipated, but it does take usually it's a 2 to 3 year lag to receive that data. So if we go to the next, and here's a sense of just the different measures of access that we're using. And these are very high level summaries. We have much more specific, we are working to, and we'll have specific codes to associate with the respective metrics that we have reported here. But the one thing that I wanted to point out here is that there are multiple types of claims files, and so we need to work across the different types of claim files. Personal summary file, there's an other service file, an inpatient file, and a prescription drug file. And so we'll be working across these different file types to facilitate the development of the various metrics that we plan to use for this study. You can see here that we have metrics where we are specifically focused on simple access, as well as the quality of services. Some of these are fairly loose quality measures. They're not strong measures of consensus-based standards of quality. But we do have some that are more, so they range in terms of the extent of evidence-based that underlies their quality assessment. But you can see things like recommended dosages for depression medication and receipt of follow-up care are more consistent with treatment guideline parameters. Psychiatric emergency department visits would just be sort of a general indicator that one would want to avert, right? And so by using that, we may be able to see if there are abilities for particular types of approaches or programs to avert psychiatric emergency department visits at the aggregate or population level. So you can see these different measures that they come from different claims files, and then we do have a number of different patient treatment characteristics, settings, and providers level variables that we'll be engaging as well to understand better some of the factors that may be associated and controlled for, that we can control for in looking at these outcomes. The next. And so I just wanted to show one example. This is from a paper that we had conducted looking at Medicaid managed care introduced for children who are specifically in foster care. So it's a very different topical area. But I think what is useful about it is that it demonstrates the utility, to demonstrate the utility of movement from of what this can do, right? So this is a paper that essentially shows how antipsychotic treatment dispensing changed pre-post policy. And then we used what we call a difference in difference approach. So we specifically looked at whether or not those that were exposed to that intervention saw a substantially or significantly different change in dispensing rates than those that were not exposed. And the lines that you see here, just to follow one of the groups in this analysis that I won't go into, but they started at those that had an FDA approved indication had 83% that had indicated that they had the claims indicated that 83% used an antipsychotic medication within that category of diagnoses. And after 24-month post policy, 83.4. So we did not see a significant reduction among those with FDA approved indications. However, if you then look down at the 44% in green, that is a population of youth who had other externalizing conditions that were not FDA approved indicated, not consistent with FDA approved indications. And we saw a reduction in use for those exposed from 44% to 39.3% after introduction of the policy intervention. And so I think that's the kind of way we used the data, just to kind of summarize some of what Ayse had said. We used the data to look at an outcome of particular relevance that the data were particularly well situated to report on, that being antipsychotic utilization. So the pharmacy claims tend to be a strength of claims-based data. And we were able to look at differences over time because of the strength of the data with regard and the continuity of program. The continuity of enrollment among children in foster care. So children in foster care tend to stay enrolled in the Medicaid system during the course of their stay in foster care. And so that also facilitated that eligibility continuity that Ayse had mentioned as being so critical to conducting these claims-based analyses. This is the kind of work that we look forward to doing in the PCORI study, to be looking at pre-post intervention, what are the within group differences, but then also looking at the comparative differences between the different program approaches that are under investigation. Next slide. So and lastly, we'll be disseminating the findings. We see Lifeline4Moms and the network that is assembled here today is really critical to our work, both in terms of helping to inform the work that we're doing and to prioritize the work that is ahead of us, but also to disseminate the findings. And so we're grateful for our collaborations that are going to facilitate the dissemination of the work that we do. As you all know, we had presented some of the work that we've done previously with regard to the program components of the access programs, and we are going to be continuing that work with a survey that we'll be fielding. Beginning in, we expected to field in February. So we held off in January because we understood that there were some access programs that are currently compiling materials to be submitted to HRSA for their respective awards. And so we wanted to wait until that process finished and then really facilitate our effort to collect. And these are surveys that are going to be electronic. We'll send them to the individual. We actually sent an email, Melissa, very thankfully, sent an email out to the contacts in each of the access programs asking who you would think best suited to respond to this survey. We have a list of individuals that we will be emailing again in February to facilitate your participation in that survey. It will essentially allow us to characterize the different approaches that are being taken across the country in your programs. And just as we've done to date, we have every intention of bringing that data back to you so you can see some of the variation and as well as the innovation that may be occurring across the access program network. And we can consider where there may be opportunities to provide that research back to some of the federal funders that are supporting your work, as well as opportunities to advocate for the work that you're doing to continue. So thank you so much. We are at time, and I will turn it back to Nancy.
Thank you, Tom, and thank you, Ayse. This was, I thought, you really made like what's extremely complicated concepts and studies. You made it very, very accessible. So we really appreciate it. And both of you presenting and everybody, as always, for your questions. And we will convene again next month. Thank you, everybody.
Thank you.